Welcome to this Mayo Clinic Laboratories recording on testing options for patients with chronic diarrhea with our presenters, Dr. Michael Camilleri and Dr. Leslie Donato. Dr. Donato, go ahead and take us away.
Thank you. Today we'll be talking about testing options for patients with chronic diarrhea with the focus on bile acid malabsorption. I have no disclosures. There are many causes for chronic diarrhea, many of which are shown here. They range from infection to malignancy, food sensitivities, autoimmune or inflammatory conditions, malabsorption conditions, and irritable bowel syndrome. There are many laboratory evaluations that can be performed in a patient with chronic diarrhea. We'll only talk about a few of them for each of the clinical conditions. For infectious disease testing, a variety of bacterial or parasitic or viral testing can be ordered, as shown here. For diseases of intestinal inflammation, such as IBS-D, there are testing such as serum CRP, fecal calprotectin, or fecal lactoferrin could be ordered. For diet-induced chronic diarrhea, such as celiac disease, a variety of testing is suggested, and those are shown here, including anti-PGG antibodies and all the way down to HLA testing as well. For malabsorption or steatorrhea, typical test options may be fecal fat analysis or pancreatic enzyme testing. And finally, for the non-specific phenotype of irritable bowel syndrome, the first order of testing may actually be to rule out non-IBS conditions and then to perform clinical evaluation of the patient. But we'll be focusing today on the subset of patients who potentially have their chronic diarrhea caused by a condition called bile acid malabsorption, where testing for bile acids would be undertaken. So bile acids aid in the emulsification and absorption of dietary fats. They're synthesized in the liver from cholesterol, and they enter into the GI system as primary bile acids, notably cholic acid and chenodeoxycholic acid. They travel through the GI system, through the small intestine, and at the end of the small intestine, the ileum, 95% of those bile acids are reabsorbed into circulation and function to negatively feedback the synthesis of bile acids in the liver. The remaining 5% of bile acids enter the colon and transverse that, and during that colon travel, they are converted by bacterial enzymes in there to what we call secondary bile acids, notably deoxycholic acid and lithocholic acid. And those are excreted in the stool, with a majority of bile acids being secondary bile acids in the stool. When a patient is deficient in some capacity for reabsorption of the bile acids in the ileum, this can lead to a condition called bile acid malabsorption that results in increased bile acids in the stool, as well as an increased percentage of primary bile acids in the stool, an increase in the concentration or the percentage of cholic acid and deoxycholic acid. In addition, the feedback inhibition from the reabsorbed bile acids is inhibited in these patients who have bile acid malabsorption. Looking at that synthesis more carefully, we see here that cholesterol is converted to cholic acid by through an intermediate called 7-alpha hydroxy 4-cholesterol 3-one, or what we call 7-alpha C4. 7-alpha C4, again, is the intermediate in the biosynthesis of bile acids, and it actually can be found circulating in serum and can be measured in that matrix. 7-alpha C4 does show some diurnal variation, and so testing really should be ordered on a fasting serum sample collecting in the morning. When when bile acid malabsorption is present, then it results in an increase in bile acids in the stool, as we mentioned, and less bile acid absorbed in the terminal ileum, leads to reduced negative feedback in the liver, also resulting in increased 7-alpha-C4 in the serum. The pathophysiology that leads to bile acid malabsorption can be from a variety of different sources, such as primary reasons, secondary reasons, other GI disorders, and even medication-induced inhibition of reabsorption, all resulting in the increased bile acid delivery to the colon, which causes increased colonic motility and transit, increased visceral sensation, increased fluid secretion, and increased mucosal permeability. All of which leads to the clinical manifestation for the patient of more frequent and more liquid bowel movements, increased stool urgency, fecal incontinence, abdominal pain, and importantly, these symptoms are similar in adolescents as well as adults. From an epidemiological standpoint, the prevalence of bile acid diarrhea in patients who have functional diarrhea can be quite high, up to about 25 to 50%. When talking about an entire community setting, the prevalence is thought to be equivalent to that of a fairly common disease that we know of celiac disease, or about 1% of the community at large. So bile acid malabsorption or bile acid diarrhea is actually quite prevalent in our community, but maybe not as well recognized. So let's talk about the lab testing options we have to evaluate a patient for bile acid malabsorption or bile acid diarrhea. The worldwide gold standard test is actually called is a radioactive test, CCAT retention test, which is actually not available in the United States, so we will not be talking about that during this talk. The two tests that are available at Mayo Clinic are the fecal bile acid test and the serum 7-alpha-C4 test. The fecal bile acid test is currently the gold standard test in the US. It requires a 48-hour collection where bile acids are measured in that stool sample. And what's nice about this test is that it can be ordered at the same time as a fecal fat analysis for evaluation of malabsorption or steatorrhea in the same patient, which is often the case. The other test option is the serum 7-alpha-C4 test. Again, fasting serum test potentially may be best used as a screening test, and we'll talk about the reasons for that in a few slides. These are the two tests that are currently clinically available. Coming soon, however, will be a panel test that includes a random fecal sample that bile acids will be measured in. So this is not requiring a 48-hour collection, plus a paired serum sample where 7-alpha-C4 will be measured. Let's focus on the first available test, the fecal bile acid test. The test code is BA48F, and it does require a consistent high-fat diet sorry, I'll start that again. The test is called BA48F. It does require the patient to maintain a high-fat diet of 100 grams of fat per day over a 4-day time period. During day 3 and 4, stool is collected, all stool sample is collected during days 3 and 4 of that high-fat diet. On day 5, all stool samples are combined and returned to the laboratory for analysis. Importantly, intestinal bacteria is found in stool and can degrade bile acids. So it's required that the stool collection needs to be stored frozen during and after collection and mailed to the laboratory frozen. Once to the laboratory, we will homogenize the stool sample, extract the bile acids, measure the most common bile acids the 5 most common bile acids in the stool by LC10 and mass spectrometry. And we will result out 2 parameters. The first is the total bile acids found in the total 48-hour collection, and it's reported as micromoles per 48 hours. The second resultable is the percent of primary bile acids, or percent of cholic acid plus keoxydeoxy. The second is this. The second reportable is the percent of primary bile acids, or the percent of Ca plus CBCA, out of the total bile acids found in the stool. The interpretation of these test results are shown here. The top right in the gray box shows the reference intervals in a healthy population, but more commonly, our clinical decision limits are used, and those are shown in green down below. When total bile acids alone are above 2,337 micromoles per 48 hours, this is consistent with the diagnosis of bile acid diarrhea or bile acid malabsorption. If the primary bile acid of Ca plus CDCA is 10% or greater, this is also consistent with bile acid diarrhea. Or if the combination of total bile acids greater than 1,000 micromoles per 48 hours and primary bile acids is 4% or greater, this is also consistent with bile acid diarrhea. It's important to note that patients currently taking or have recently taken oral antibiotics will have reduced conversion of primary to secondary bile acids, and it can take up to 3 months to restore the microbiome. Patients with severe liver disease or dysfunction will have low total bile acids because of impaired synthesis. And importantly, when ordering this particular test, a random stool sample is not acceptable because we do report out the total concentration of bile acids in that 48-hour sample. But remember, the combination test is coming that will allow for a random stool sample. Lastly, what's a nice advantage of ordering this test is that a fecal fat test can be ordered on the same exact sample as what's submitted for fecal bile acid testing on the same 48-hour stool collection. The second testing option that's available is that serum 7-alpha-C4 test, where we measure 7-alpha-C4 in a fasting serum sample. The methodology is LC10 and mass spec, similarly to the bile acid test, which has high sensitivity and specificity for the measurement of only 7-alpha-C4. Reference interval is shown at the top again, but again, clinical decision limits are usually used for the interpretation of this test. A low cut point of 17.6 has actually very good rule out clinical performance, such that a concentration less than this is highly unlikely that the patient has bile acid malabsorption. A relatively high concentration of 7-alpha-C4 in the serum of 52.5 or greater is quite specific for the condition of bile acid malabsorption and can be considered a rule-in criteria. Physicians may choose to use an interpretation such as this, whereas, again, ruling out bile acid malabsorption could be concentrations of lower than 17.6 nanogram per mil of 7-alpha-C4. Ruling in could be a concentration of 52.5, where a physician could then go on to treat the patient with medications to treat that bile acid malabsorption, which Dr. Camilleri will go into in a few slides from now. In between these two concentrations could be considered more of a gray area, where the physician could decide to order confirmatory bile acid, fecal bile acid testing, or potentially try a trial of treatment options for the patient to see if symptoms are alleviated. The panel test coming soon will incorporate a random fecal bile acid sample plus the serum 7-alpha-C4. It will require 2 samples to be submitted, a random or spot stool collection. What's nice about this option is that no patient preparation is required. So no high-fat diet and no long-term collection. But it's important to know that only the % of primary bile acid will be reported on this sample. The second sample to be collected will be the fasting serum sample on the same patient at or around the same time as the stool sample collection. And the collection and the resulting is exactly the same as the single orderable test for 7-alpha-C4. The interpretation of this combination test are shown here, where a result of serum 7-alpha-C4 of greater than 52.5 nanograms per mil and a primary fecal bile acid result of 10% or greater has 66% sensitivity and 95% specificity for bile acid diarrhea. So looking at the 3 testing options, we go from the good option of serum 7-alpha-C4 as a very good screening test for bile acid malabsorption. The gold standard test at the top is potentially the best test option for the 48-hour stool sample, but does require that high-fat diet and long-term collection. And potentially in the middle option could be considered the combination test coming soon, which will have the result of a spot stool sample as well as the result from a fasting 7-alpha-C4 test in serum. If we look at the pros and cons of these 3 test options, the serum 7-alpha-C4 test on its own is easy collection. Patients are accustomed to a venipuncture and a fasting serum draw, and can be a great option for a mailed-in order for screening. On the right side is the standard fecal bile acid test requiring that 48-hour stool collection. This, again, is ideal when ordering other tests on a stool sample, such as the fecal fat on the same sample, but it may be difficult for the patient to perform the collection and may be unpalatable for them. So given these challenges, the better option may be this combination panel of the spot stool collection with a fasting serum sample. This may be ideal for patients to actually perform their stool collection during the physician-patient encounter, such that taking home a collection kit may not even be required. I will now turn the presentation over to my colleague, Dr. Michael Camilleri, who is a professor in the Division of Gastroenterology and Hepatology with more than 40 years of experience treating patients with GI-related disorders and is a worldwide expert in the condition of bile acid malabsorption. Dr. Camilleri.
Thank you, Leslie. Thank you for the opportunity to give you some clinical perspectives on bile acid diarrhea. These are the relevant financial relationships. We have performed single center studies of medications that are in development for the indication of bile acid diarrhea. And you can see the grant support came from Novartis, Allergan, and NGIM Biopharma. And I will be talking on off-label usage of bile acid sequestrants, cholestyramine, cholecipol, and cholesavelam. Let's go to the next slide, please, Leslie. So when we see patients with chronic diarrhea, we often ask the patients, do you have any blood with your bowel movements? When you flush the toilet, does the stool sink or does it float? And have you had any unintentional weight loss? Those tend to be what we call alarm symptoms. And if the patient doesn't have alarm symptoms, then we are moving down into what we would call the chronic functional type of diarrhea. But let me just remind you that if the patient has blood per rectum, then we're going to do a colonoscopy and biopsy. If they have indicators of fatty diarrhea, then we're going to do small bowel biopsies, imaging biopsies, and aspirates for bacterial overgrowth. If they don't have any of these features, and they don't have any unintentional weight loss, then we're suspecting either irritable bowel syndrome with diarrhea or chronic functional diarrhea. We will then perform some dietary exclusion if the patient has identified such an item in the diet that's causing the diarrhea, such as lactose. And then we will perform a limited screen for organic disease. This usually involves a complete blood count, a biochemical profile, and especially if we're thinking of inflammatory bowel disease, we will measure serum C-reactive protein, erythrocyte sedimentation rate. If they have features to suggest malabsorption, we might request serum iron, folate, B12. If we're considering celiac disease, tissue transglutaminase IgA, we might also send off a stool sample for excess fat or calprotectin. But as Dr. Donato has mentioned, in the future, a very simple thing that we will do when we encounter the patient is measure the serum 7-alpha-C4 and also send that same stool sample that we are collecting for, say, calprotectin, because we're suspecting possible inflammatory bowel disease. That same sample can also be sent for primary bile acid measurements. So we're seeing that the combination tests could fit in very nicely into this limited screen for organic disease. And the rationale, again, is that if we're going to screen for celiac disease in somebody with diarrhea, the population prevalence, the community prevalence of bile acid diarrhea is virtually equivalent to that of celiac disease. So we should develop a practice of screening for celiac disease in addition as well to screen for bile acid diarrhea when we encounter patients with chronic functional diarrhea. Next slide, please. So when we see these patients, we sometimes have indications of the elevation of serum 7-alpha-C4, and that will be our screening test, after which we will likely, in the patient who has persistent chronic diarrhea, we may measure full gastrointestinal transit, and that helps us to titrate the treatment that we give to the patient. Do we just use something simple to slow down transit? Or if the patient has an elevated serum 7-alpha-C4, or they have elevated total 48-hour fecal bile acid excretion, then we're going to be using the bile acid sequestrant. Now you'll see from these two slides I've shown you that these were algorithms that were developed for articles published in 2017. And since then, the work that has been done by Mayo Clinic's Department of Lab Medicine and Pathology has really emphasized the importance of making a positive diagnosis, not just empirically trying to see whether the patient responds to a bile acid sequestrant. Now we have the tools to actually make a definitive and positive diagnosis when we see patients with chronic diarrhea. Next slide. We know that bile acid diarrhea may also be a contributor to this diarrhea that happens in other diseases, in addition to chronic functional diarrhea or irritable bowel syndrome. So when we looked very recently at patients seen at Mayo Clinic with other diarrheal diseases, and I'll explain these in a minute, we found that a fairly significant proportion of these other diseases also had a component of bile acid diarrhea. And you will not be surprised, of course, if the patient has had an ileal resection, let's say due to terminal ileal Crohn's disease, then their ability to reabsorb bile acids is markedly diminished. And therefore, a higher concentration of bile acids is going to get into the colon and cause the diarrhea. Similarly, if the patient has had a colectomy with ileal pouch anal anastomosis, they pass a large amount of bile acid, high concentration, into the pouch, and there it can actually cause pouchitis and severe diarrhea. But we've also identified that patients without any resection, without any surgery, patients with celiac disease, which may even be patients who have already had benefit from gluten withdrawal, they may also have bile acid diarrhea because, as you know, the ileum can also be involved in celiac disease. Similarly, the terminal ileum can be involved in microscopic colitis. And finally, patients with neuroendocrine tumors like carcinoids will often have had a resection of the terminal ileum, but we've also shown that even with minor resections of less than 25 centimeters, less than 1 foot of ileum resected can also be associated with bile acid diarrhea. Let me show you some of those data on the next slides. Well, before I do so, let me also tell you that it's really important to make a positive diagnosis. The positive diagnosis is made by the tests that Dr. Donato has explained to us. I'm just going to summarize the experience from about over 900 patients that we saw here at Mayo Clinic in the last few years. About 50% of those patients with unexplained diarrhea had elevated fecal bile acid excretion, usually because of the elevation of the total fecal bile acids or because of elevation of just the primary fecal bile acids. As Dr. Donato mentioned, if you have more than 10% of the bile acids in the stool being cholic acid or chenodeoxycholic acid, that constitutes a good diagnostic test for bile acid diarrhea. Now, importantly, when we looked at the medical records and we saw the patients who had had a definitive diagnosis of bile acid diarrhea and were given one of those 3 bile acid sequestrants, cholestyramine, cholesavelam, or cholestyramine, you can see that there's about a 67 to 75% response rate to those treatments. In contrast, in the same period of time, we also look to see what is the therapeutic response if the patient just had chronic diarrhea and the physician decided to put them on a therapeutic trial of one of those 3 bile acid sequestrants. The response rate in that group was only 25%. So if you make a positive diagnosis before you treat the patients, you have a 3-fold likelihood of responding to the bile acid sequestrant. And especially if the combo test is introduced, pari passu with our screening for inflammatory bowel disease with serum C-reactive protein and fecal calprotectin, if we do a serum 7-alpha-C4 and a fecal primary bile acid measurement, we can make the diagnosis much more effectively and treat the patient much more effectively with the appropriate bile acid sequestrants. Next slide. We also know that in the same cohort, the patients who have the diagnosis of bile acid diarrhea, if you look at the right side of the slide, you'll see the types of tests that were also done in these patients in an attempt to identify the cause of the diarrhea. Now, you can see in the middle of part of the slide that the tests were done equally for the patients who ended up with a bile acid diarrhea diagnosis or normal bile acids in the stool, whether it was upper GI endoscopy, biopsies, colonoscopy, etc. You can see the histograms show an equal distribution of those tests for transaction imaging, endoscopic procedures, or miscellaneous testing. But now go back to the image on the right side, and you can see that the transaction imaging, the CT scan, the MRI, only gave us the diagnosis in 4% of those patients. The endoscopies, including biopsies, only gave us the diagnosis in 5% of those patients, whereas the other tests only gave us a diagnosis in about 8% of the patients. So the fact of the matter is that there is an opportunity to reduce healthcare utilization by early adoption of the 48-hour fecal bile acid evaluation, which is what we studied in this particular analysis. And I think in the future, we think this is going to be even more cost-effective once we have the combo test that Dr. Donato mentioned, which is the random stool sample for primary bile acids and the fasting serum 7-alpha-C4. Next slide. So in summary, these are the take-home points from a clinician's perspective. 25 to 50% of patients with chronic diarrhea have bile acid diarrhea. This is about 1% of the general population. It presents usually with an increased frequency of bowel movements, a more loose stool consistency as measured, for instance, by the Bristol Stool Form Scale. Very often the patients have urgency. some of our patients have told us they have so much urgency that they need to be close to a restroom, close to a bathroom, to avoid the fear of fecal incontinence. And that obviously results in a reduction in their quality of life. We also have seen that bile acid diarrhea may be a component of other diseases, and I mentioned celiac disease, microscopic colitis, as well as diseases like ulcerative colitis of Crohn's disease that may be associated with resection of parts of the intestine. We can now make a positive diagnosis of bile acid diarrhea using this fasting serum 7-alpha-C4 as a screening tool, a definitive test with the 48-hour stool collection for total bile acids or percent primary bile acids. And in the future, we're anticipating an impact from a simpler approach, which is to do the fasting serum 7-alpha-C4 and the random stool sample for primary bile acids. And finally, there are many bile acid sequestrants that are available to us: cholestyramine, cholesavolame, and cholestyramine. I just want to remind any clinicians who may be prescribing these medications that they are very efficacious at binding other medications that are taken within 2 hours of taking these bile acid sequestrants. And so in my clinical practice, I usually give a morning dose at least 2 hours after breakfast and 2 hours after the morning medications are taken. And then I give the last dose just before bed in order for these sequestrants to bind the bile acids that are circulating through the small intestine during the night time. And then those bile acids are taken down into the colon by the sequestrant and excreted in the stool. And that way, it reduces the pool of bile acids circulating through the gastrointestinal tract and thereby reduce the risk of bile acid diarrhea. Thank you very much for giving me the opportunity to participate.
Thank you, Dr. Camilleri and Dr. Donato, for sharing this information. If there are any questions about the content in this webinar, you can please contact the email address provided on the screen. Thank you.